It's May 27, 2022, Memorial Day. A few days before EULAR begins. But no, it's the Room Now podcast, and I'm Jack Cush with Room Now. This week on the podcast, it seems like we have a lot of recommendations. New drugs, things to do in fibromyalgia, testing, monitoring, and it seems like it's all a bunch of hooey, but we're going to discuss it anyway. Let's start with an announcement that came out this week from the EMA and their committee that makes decisions on recommendations for new drugs and their indications. The CHMP has recommended a number of rheumatology drugs that are already approved in the EMA and the US, but in the EMA they're not yet approved for these new indications. So secukinumab, Cosentyx, there's a recommendation it be approved for juvenile PSA and ERA in kids. As you know, it is approved in the United States for those indications, but seems like the EMA is going to follow suit. Olumiant or baricitinib is going to have its day with the great new alopecia areata data, and that seems like that's going to happen. Upadacitinib or Rinvoq is up for approval, a new indication, that being ulcerative colitis in Europe. And lastly, although it's approved in the United States, tofacitinib or Xeljanz has yet to be approved in Europe, but is now up for approval with the recommendation of the CHMP. These are not final decisions. The EMA still has to rubber stamp this for those to go through, but it looks good for those drugs. A nice study about gout, I think, heightens a concern of mine, and that's gout and hypertension. A cohort of 100 patients with gout, half of them had hypertension. Nearly half of them, it was not well controlled. It was undiagnosed in almost 20%. And when gout and hypertension existed, usually like 90+% of the patients were not yet at their target uric acid levels. So we know that comorbidities are usually mean worse disease or poorly controlled disease, and that seems to be the case here in gout, where, as you know, comorbidities are rampant. But if you have a gout patient with hypertension, you better start paying attention because I think the outcomes here are not going to be good. That's why we see more cardiovascular events, more renal disease, etc. Another study that looked at non-hospitalized gout patients, hospitalized gout patients, 1,000 of them, saw an inverse relationship between whether the gout patients had CKD, kidney disease, or non-alcoholic fatty liver disease, and that there was a negative association between those. What? What does one have to do with the other, and does it even matter? Again, there's a recommendation that you should be mindful of this, but is this not like a statistical oddity? I look at this data, and there are negative associations, meaning if you're a gout patient and you have fatty liver disease, you're less likely to have kidney disease. And so what does that mean? Again, sometimes I look at reports like this and I say, are they just fishing for p-values here? Are they trolling for p-values here? What are they doing? Because this doesn't make much sense to me. This is a study out of China, and you know, in Southeast Asia there's a whole lot more liver disease. So I'm not really sure what this means. And my takeaway message is it means nothing, and I just wasted 60 seconds of your time. I'm not going to waste your time. I'm going to point you towards a New England Journal case. It's one of them clinical images things that the New England Journal has. It's worth looking at, especially if any of you who are below the age of 50. Why? Because it's a case of reactive arthritis. And you don't see reactive arthritis. In my fellowship, I saw a lot of reactive arthritis, and that was the beginning of the HIV era, and people started using a lot of condoms, and all of a sudden, boom, reactive arthritis went away. We don't see much reactive arthritis anymore. Fellows don't see it in the emergency room like I did when I was in my fellowship. This is a 40-year-old case with a 2-week history of a scaly foot rash. Keratoderma blennoragicum, say that 3 times fast. Forget it, spell it for me, and you win today's prize. Keratoderma blennoragicum had low back pain. All this occurred a week or 2 after diarrhea and a urethral discharge. There was a psoriatic rash on the scalp, trunk, hands, nail changes, a few swollen joints, a CRP of 59, sterile pyuria, and HLA-B27 positivity. This is really reactive arthritis. These patients respond well to acute therapy. Good luck trying to get them on chronic therapy because they're nomadic and they hardly ever come back. That was my experience back in the 80s. We don't have a lot of sort of longitudinal studies of reactive arthritis. Again, if you haven't seen reactive arthritis, you should look at the pictures. They're kind of disgusting, but really telltale and very accurate, and read the case. It's very worthwhile. I like the study about lupus and pulmonary embolism, a study of 86 patients, average age 38 years. They had lupus for about 4 years, and overall 20% of them died. Didn't say whether it was directly due to the PE. Of those that lived, the 3-year survival rates were 79%, meaning 21% of these people died. Bottom line is, having PE and lupus is probably a bad thing. And I know you certainly do testing for antiphospholipid antibodies. Lupus anticoagulant is the one test that you should be doing, according to Michelle Petrie. The predictors of mortality in this cohort was the presence of thrombocytopenia and lymphocytopenia. The patients who did the best in this cohort, those that were on hydroxychloroquine, it has antithrombotic effects, and those who received early anticoagulation, not surprising there. Another report about nonsteroidals in COVID. I don't even know why this is even an issue, but it keeps showing up like it could be an issue. Put this in the ivermectin hydroxychloroquine bucket when talking about about COVID. But this study, which looked at 38 centers, retrospective cohort, propensity matched EHR data, shows no association between untoward outcomes with COVID, and that includes all-cause mortality, ventilation, kidney failure, the need for ECMO, hospitalization. Again, being on a nonsteroidal had no effect on this, and that doesn't surprise me. I'm not sure why it would. The drug is not immunosuppressive. It's not involved in the biology of ACE2 receptors or how the spike protein attaches. I'm not sure why this was done. Another interesting study, anti-neutralizing antibodies. We're going to get into this later in talking about TDM, but this study of 282 inflammatory arthritis patients who had assays for, and they were all on TNF inhibitors. How many do you think had anti-neutralizing antibodies? So this would probably be infliximab, adalimumab. It's low. It's 3.9%. Is that worth even measuring? My opinion, no. But if you did, and if you're one of the 11 out of the 282, and you had these, you're more likely to be a smoker, have higher disease activity, worse function, and higher inflammatory markers. Wouldn't you be worried about those people based on smoking, disease activity, poor function, and inflammatory markers? I don't think anti-drug antibodies here, neutralizing antibodies, are important in my decision making. But those of you who like such assays, hold on, we're going to talk about TDM. Let's go right to TDM right now. EULAR put out a position piece, EULAR guidance on therapeutic drug monitoring, or TDM. Bottom line, 5 overarching principles, 13 recommendations. They say that after the literature review and discussion by their expert panel, that they cannot proactively recommend therapeutic drug marketing, but that maybe in certain scenarios you should do therapeutic drug monitoring. And what they're talking about here is always doing the neutralizing antibody tests with the serum or plasma levels of the antibody, like infliximab or adalimumab, when paired together. Maybe it helps you in understanding why someone had a loss of efficacy or why someone had a hypersensitivity reaction. But honestly, is it worth the hassle of getting the test and waiting for the results to make a decision? You've got plenty of other options. Move on. I don't do therapeutic drug monitoring. Who does? It's mostly GI, and there's some advocates for this in dermatology. But remember, in GI and dermatology, they're not always on chronic infliximab or adalimumab. They tend to go on and off, right? They tend not to be on background DMARDs like methotrexate, leflunomide, azathioprine, etc. So for these reasons, maybe they're more likely to have anti-drug antibodies, especially if you're starting and stopping. a nice study came from the VA Center looking at multimorbidity. I don't know if you've seen the room now has got a replay of Elena Mayasadova's video and lecture at Room Now Live on multimorbidity. Really worth looking at. It's a short half-hour video. This study of 345 patients showed that RA patients do have more multimorbidity. That means more than one comorbidity. And the ones that are most represented are cardiopulmonary, cardiometabolic, mental health, and chronic pain disorders, where there's a 17% to 300% increased risk of having those. JAMA had a useful paper giving you a comparative analysis of amitriptyline versus FDA-approved therapies in patients with fibromyalgia. We don't often discuss fibromyalgia. They looked at almost 12,000 patients in this cohort and looked at 60 and 120 milligram doses of Cymbalta duloxetine compared to 300, 450, and 600 milligram doses of pregabalin, Lyrica, or 100 and 200 milligram doses of milnacipran or Savella, and they compared these to amitriptyline. In the end, in the comparisons, the things that stood out was duloxetine was better and had the best control of pain and depression, and amitriptyline was more effective than the others at sleep control and quality of life, and only a lot of those other drugs had a high dropout rate. The one that had the least dropout rate was amitriptyline or Elavil. I think this informs and supports what I in fact do. I use trazodone and amitriptyline for sleep and quality of life and fatigue, not for depression. I don't know that it does much for pain. But if I'm dealing with pain, I do like to use duloxetine over the other agents. I've not really had, and we've talked before about especially duloxetine not doing very well in comparative analyses or population or large population-based studies post-marketing. Its effects have been sort of hit or miss. But in this study, it looked pretty good looking at the published literature. Annals Rheumatic Disease had a viewpoint, what I would call a think piece, about can the SGLT2 inhibitors be protective in patients with lupus nephritis or GPA? It's a very interesting idea because these sodium glucose cotransporter 2 inhibitors, SGLT2, are all the rave right now in the renal literature and the cardiovascular literature, where better outcomes, better renal outcomes, better survival have been consistently seen. So much so they're saying that patients should probably be, all patients with, either diabetes, renal disease and diabetes, or heart failure should be on these as adjunctive therapy. We're talking about drugs like Invokana, Farxiga, or Jardiance. I'm not going to give you their generic names, too hard to pronounce. How do they work? Hard to know. They cause a natriuresis, reduction in plasma volume. They reduce adipokines and other pro-inflammatory cytokines, reduce oxidative stress, lower uric acid levels, and reduce GFR and albumin secretion by the kidney. So again, these we do use a lot of renal protective therapy in our patients with lupus nephritis. Calcium channel blockers, for instance, or ACE inhibitors. Here, this might be replacing that. Look for studies in this in the future. Our last report comes from Dan Solomon's group on cardiovascular risk in patients with calcium pyrophosphate disease. I found this interesting because I certainly know about cardiovascular risk in RA, in chronic inflammation, in gout patients even, but I am not aware of anything that would say the same exists for patients who have calcium pyrophosphate arthritis. And this is looking at patients within the EMR system for the Mass General and Brigham Hospitals EMRs, and they studied patients almost over a 20-plus year period, and they found 1,200 patients with a diagnosis of acute calcium pyrophosphate arthritis, and they compared that to 3,800 matched comparators, and guess what? Those who had acute calcium pyrophosphate arthritis, and I assume that these are presentations to the emergency room, that had a significantly higher, a 32% higher risk of MACE in the first 2 years after the arthritis was identified. This sort of panned out over time, that this was seen not only for MACE events, but also other non-fatal cardiovascular events. The best results were seen in the first 2 years. It became a little less obvious in years 2 through 10 in long-term follow-up, suggesting that, again, if you're bad enough to get acute calcium pyrophosphate disease, you're probably going to have chronic inflammatory calcium pyrophosphate disease, and inflammation probably is driving that risk, but that's an extrapolation on my part. We would certainly like to see more studies of this. I want to remind you, next week, starting on Wednesday, EULAR is beginning. It's day 1 of EULAR. Room Now will be reporting from Copenhagen. We'll have our faculty there. We'll be reporting each day as it happens. They be published around 4 or 5 p.m. Eastern time every day. So we'll be here having day 1 reports on day 1, 2, 3, and day 4 on Saturday. You'll be getting a report as well. Again, look for a lot of good articles, a lot of great tweets, and also a lot of good videos and podcasts coming out of that meeting. Tune in. It's going to be exciting next week at EULAR. Bye-bye.